Good afternoon, everyone. The topic of my presentation is guidelines on opioid substitution therapy, and my moderator is Dr. Sanjeevna. Dr. Shelley's So in this presentation, we'll be studying about a basic introduction, the substance use disorder, opioid substitution therapy, about the drug buprenorphine, and clinical practice guidelines for OST centers, which come under National AIDS Control Program, and some of the guidelines from Indian Psychiatric Society. Evidence-based treatment of opioid dependence is an important public health priority in many parts of the country. Opioid agonist medications are regarded as the first-line treatment of opioid dependence. Opioid substitution therapy has been instrumental in reducing morbidity and mortality and has proven effective in restoring the lives of millions of opioid-dependent patients. So opioid, it is a group of psychoactive substances that are similar to the action to that of opium poppy. It is extracted from the plant Papaver somniferum. They act specifically in a set of receptors in humans that are mu, kappa, and delta, which are called the opioid receptors. And some of the common opioids include natural derivatives like morphine, codeine, semi-synthetic are buprenorphine, heroin, and synthetic are methadone, dextro, propoxyphene, and pentazocine. So, substance use disorder under the International Classification of Diseases, 10th revision, given by the World Health Organization, two distinct diagnostic entities exist. First is the harmful use, and second is dependence. So, harmful use is a pattern of substance use in which a user experiences physical or psychological harms by substance use, and despite such harms, continues to use the substance. And dependence is, it is a pattern of substance use in which the substance is used on a daily or almost daily basis, and the substance use and associated behavior takes precedence over other behaviors or activities that were important to the individual. So when we call it a dependence syndrome, when the following criteria should be fulfilled for at least 3 months in 1 year period. First is use of substance in high amounts over a long period of time. Second is need to increase the quantity of substance to get the same pleasure, that is tolerance. Then appearance of specific physical or psychological symptoms upon stopping or reducing the amount or use of the substance, that is withdrawal symptoms. Then intense desire to consume the substance, that is craving. Continued use of the substance despite the harm. Significant socio-occupational dysfunction due to substance use. And significant time spending in procuring, using, recovering from the substance in a day. So usually an individual, it progresses from the stage of use, then to the harmful use, and then it goes to the dependence. As stated earlier, the stage of harmful use and dependence are clearly morbid and are diagnostic entities. The time taken to progress from one stage to another, it is different in different persons and the substances that they consume. For example, an opioid user usually progresses rapidly within weeks from first use of the dependence. So opioid dependence syndrome, it is a pattern of opioid drug use in which an individual uses opioids on a daily or almost daily basis and fulfills the criteria for dependence on opioid drugs. Some of the features of opioid dependence syndrome are as follows. First are the acute withdrawal, in which there is lacrimation, rhinorrhea, yawning, diarrhea, muscle cramps, sweating, muscle aches, and pains. Along with these symptoms, other symptoms include anxiety, restlessness, insomnia, irritability, as well as intense urge or craving to consume the opioid, and it is self-limiting in nature. Then there is protracted withdrawal, which is up to 4 to 6 months. There are mild aches and pains, loss of interest in pleasurable activities, premature ejaculation, sleep disturbances, and craving. These symptoms are also some reasons for relapse in a number of opioid users. Then there is relapsing nature of the illness. An individual may restart using opioids after a period of abstinence. Such relapses and remissions are a feature of opioid dependence syndrome, especially among those who have used them for prolonged periods, that is years. Then there is high-risk behaviors like the people who use opioid with the help of injectables, then they have higher chances of bloodborne infections like HIV, hepatitis B, hepatitis C, and a result of which HIV prevalence among these individuals is very high. Then multiple harms, like a opioid dependent user may incur harms in multiple domains. like family complications, broken families, family fights, domestic violence. Legal complications may include illegal activities like stealing, drug peddling, petty thefts. Social complications may include loss of reputation or social status, being a social outcast, ridicule from the society, sometimes even inhuman treatment or physical torture. So now we'll be studying about the basic concepts and principles of the opioid substitution therapy. It is a recognized, effective, evidence-based, and generally safer option for treating opioid dependence worldwide. Short-term treatment of opioid dependence lasting for a couple of weeks called detoxification, which involves management of acute withdrawals alone, is associated with a very high rates of relapse. Long-term treatment is hence necessary for opioid dependence. And it is one opioid substitution therapy is one such long-term treatment option. And these include mainly oral substitution like buprenorphine, medication-assisted treatment, buprenorphine maintenance treatment, methadone maintenance treatment, etc. The opioid medicines used for OST relief drug-related withdrawals and craving and do not lead to acute intoxication. Opioid medicines used for OST, they act slowly and for a longer period of time, for at least 24 hours. Opioid medicines that are used for OST are administered orally or sublingually, which is a much safer route. The potency and purity of opioid medicines that are used for this substitution therapy is known. This helps in averting the overdose situations. The opioid medicines which we use for substitution therapy are available in government supported centers or hospitals free of cost. The patient does not have to resort to illegal means. And when a OST is started, then the drug user are seen as the sufferers and patients. So the benefits of opioid substitution therapy are reduction in the opioid use, reduced overdose-related deaths, reduction in criminality, reduction in domestic violence, improved childcare and family ties, improved productivity, reduction in injected behavior, and improved adherence for other treatments, especially treatment for HIV, tuberculosis, and viral hepatitis. Then the key characteristics of the substitution therapy are, it is primarily a medical intervention. Adequate dose of medicines is one of the most crucial determinants of a good outcome. Long duration of retention in continuous treatment is essential for a good outcome. Combining psychosocial interventions along with dispensing of medicines forms the complete treatment package. Involving the patients at all treatment stages, it is also crucial for the success. Then the medicines which we use for opioid substitution therapy, they have an action similar to the illicit opioid that is used by the patients. They have lesser addiction potential as compared to the illicit opioid being consumed by the patient. They are easy to administer, have long-lasting action at least for 24 hours, tolerated well. They are cheaper, easily available, easily stored and transported. The pharmaceutical compounds commonly used as OST medicines, these are methadone. Methadone was the first and currently the most common opioid used as an OST medicine globally. Methadone is a pure opioid agonist available for oral use either as a liquid or as a tablet. Second is buprenorphine. It is a partial opioid agonist available for use as a sublingual tablet. It is the second most commonly used OST medicine worldwide. Then there are slow release oral morphine. Morphine is a pure opioid agonist and commonly used in cancer patients for alleviation of pain. The slow release formulations is available as a tablet. Then the current status of opioid substitution therapy in India. It is currently available in 77 countries. Of these, most countries use methadone as the OST medicine followed by buprenorphine. In India, OST has been available since the early 90s when buprenorphine started being used in some government hospitals as well as in some of the NGO settings. The NGO OST centers were subsequently supported under National AIDS Control Program, while the government centers continued to provide OST for opioid-dependent individuals through funding from the Ministry of Health and Family Welfare. Additionally, there are anecdotal reports of opioid substitution therapy being provided through private drug treatment centers. So mainly the drug which is used for opioid substitution therapy is buprenorphine. So we'll be studying now about buprenorphine. Buprenorphine, it comes under partial agonist. These are the partial agonists. They exert 100% action on mu receptors, producing opioid-like effects, but less than opioid agonist. Example of a partial agonist is buprenorphine. Then the agonist, which opioid agonists bind to and activate the mu receptors, thereby exerting 100% action, producing opioid-like effect. The full agonists, these are morphine, codeine, dextropropoxyphene, heroin, and methadone. And then there are antagonists, which bind to the mu receptors but do not produce any action by themselves. They just stop the action of the other opioid which are to act on these receptors. These are namely naloxone and naltrexone. Buprenorphine, it is a partial agonist of mu receptor and an antagonist of the kappa receptors. So with lower doses, the action of the partial agonist is similar to that of a full agonist. As the dose increases, of both the partial agonist and the full agonist, partial agonist dose is also increased, and the full agonist, that is morphine, its dose is also increased. However, beyond a certain dose point, further increase in the buprenorphine, it does not increase the opioid effect. So this is known as the ceiling effect, which is seen with buprenorphine. So the chances of overdose-related respiratory depression and consequently death, these are minimal with the higher doses of buprenorphine. Buprenorphine, it has a high affinity for opioid mu receptors. Then buprenorphine dissociates from opioid receptors slowly as compared to other opioids. Thus, buprenorphine is a long-acting opioid with terminal elimination half-life of 24 to 37 hours. The 2 mg tablet, its clinical effect is up to 12 hours, and the 16 mg, its clinical effect is up to 48 hours. Then the buprenorphine undergoes extensive metabolism in the liver and is converted into norbuprenorphine and other products through the cytochrome P450-3A4 enzyme. The metabolites, they do not have any major effect on the brain due to the poor penetration. Most of the metabolites, these are excreted through feces and some through urine. The common side effects of buprenorphine are constipation, sedation, sleep disturbances, body aches or pains. These are the features of withdrawal. They can be due to the lower doses also. Nausea, vomiting, itching, dizziness, headache, sweating. Then drug interaction. Buprenorphine, it has drug interaction with sedatives. The brain depressant effect of buprenorphine is additive to concomitant use of the sedatives. These sedatives include benzodiazepines, barbiturates, and alcohol. Then opioid antagonists. Buprenorphine prevents other opioid antagonists from exerting Buprenorphine prevents other opioid agonists from exerting their effect due to strong affinity to opioid receptors. Conversely, buprenorphine displaces opioid agonists, resulting in precipitated withdrawals. Then hepatic enzyme inducers or inhibitors. Buprenorphine, it is metabolized in liver through cytochrome P40-3A4 enzymes. So we have to look for specific drugs that are the inducers of cytochrome P40-3A4 and some of the drugs which inhibit cytochrome P450-3A4. The drugs which induce these enzymes, in these, we have to increase the dose of buprenorphine, like anti-epileptics like carbamazepine, phenobarbital, phenytoin, anti-tubercular drugs like rifampicin, antiretrovirals like efavirenz, nevirapine. Then the drugs which inhibit cytochrome 450-3A4 enzyme, buprenorphine dose has to be decreased in them. These drugs are antifungals like fluconazole, ketoconazole, antibiotics like erythromycin, antidepressants like fluoxetine, fluoxamine, paroxetine, antiretrovirals like indinavir, ritonavir, and sacubitril. Then the abuse liability of buprenorphine. As buprenorphine is an opioid mu receptor agonist, though it is a partial agonist, it is liable to be abused. In individuals who are not dependent on opioids, buprenorphine used through sublingual route produces euphoria and other opioid-like effects. Among drug users, buprenorphine is often the preferred opioid used for injecting in India. As sublingual buprenorphine is easily dissolvable in water, it can be diverted for injection purposes. Thus, one should exercise caution in dispensing of buprenorphine to opioid-dependent individuals, and hence in the National AIDS Control Program, buprenorphine is almost always dispensed as directly observed treatment. The patient comes to take the buprenorphine. He is given buprenorphine in the presence of the doctor, and after that, for 7 to 10 minutes, he is kept there under observation. Then the formulations and legal status in India. Currently in India, buprenorphine is available both in injectable and sublingual tablet form. The injectable form is commonly available as 2 ml ampules with each ml containing 0.3 mg of buprenorphine. The injectable form is used as an analgesic. The sublingual tablets of buprenorphine are currently available in three strengths, 0.2 milligram, 0.4 milligram, and 2 milligrams. Buprenorphine is classified as a psychotropic under the Narcotic Drugs and Psychotropic Substances Act. However, these medications should be prescribed by a doctor and can be made available only in government-recognized centers. The injectable form and the 0.2 milligram tablet is available in pharmacies where these formulations can be sold upon availability of a valid prescription for the same. However, the highest strengths of 0.4 and 0.2 milligram, they have been approved only for the purpose of treatment of opioid-dependent individuals and can be made available only in government-recognized drug treatment or de-addiction centers. Then the clinical practice guidelines for opioid substitution therapy centers under National AIDS Control Program. The assessment is to be carried out both by the counselor as well as the doctor at the OST center, though the doctor take a larger role since OST is a medical intervention. In assessment, we have to first establish the rapport with the patient, then we have to establish the diagnosis, then to decide the eligibility for the opioid substitution therapy, then decide the dose of buprenorphine, and then we have to see if we need referral or management for other conditions. The assessment modalities are interaction with the patient, interaction with the family members, if present during the assessment, interaction with other individuals associated with the patient like friends, staff of the IDU, if present during assessment. Then review of the previous treatment records if available, and observation and physical examination of the patient. Then the assessment areas in which we have to assess the patients are socio-demographic details, psychoactive substance use detail, complications due to the substance use, injecting and other high-risk behaviors, past abstinence attempts, history of any medical illness, current psychosocial support and living arrangement, current status of the occupational and family functioning, evidence of current opioid withdrawals or intoxication, evidence of injection or other physical consequences of substance use like injection marks, abscesses, scars, etc. Then determining the suitability of the patient for opioid substitution therapy. To be initiated on opioid substitution therapy, the patient must fulfill the suitability criteria, which is divided into essential criteria, while the others are desirable. Under the essential criteria for opioid substitution therapy, first of all, which is needed is diagnosis of the opioid dependence syndrome, then current injectable drug use, absence of medical contraindication, informed consent, and patient's willingness to come daily to receive the treatment. Under the desirable criteria, it is age more than 18 years, failed abstinence attempts, long duration of opioid use or injection, motivation to give up drug use or injection, and the feasibility. While the following criteria are desirable, they are not essential for a patient to be initiated on opioid substitution therapy. These criteria have been included as they increase the likelihood of selecting a suitable client for a patient for opioid substitution therapy, thereby increasing the confidence of the clinician in prescribing the treatment. Then preparing the individual for opioid substitution therapy by finding out the nature of the illness, nature of the treatment, need for active involvement, and to sign the informed consent. The buprenorphine-based opioid substitution therapy, it is given in 3 phases. First is the induction phase, where the patient is given the first dose and the dose is subsequently adjusted to achieve a stabilization dose. In maintenance phase, there is a stabilization dose which is maintained till a decision to stop the buprenorphine is taken. And in the termination phase, the phase from decision to stop the buprenorphine to the last dose of buprenorphine. Then in the induction phase, the goals of the induction phase are to determine the correct dose of buprenorphine for a patient to be able to control opioid withdrawal symptoms and craving, to address any medical or psychosocial crisis that is faced by the patient, and to establish the rapport with the patient and educate him or her about the treatment process. Then dose of 2 to 4 milligram per day, it is given to control the opioid withdrawal symptoms. Dose of 4 to 8 milligram per day is used to control the opioid related cravings, and more than 8 milligram per day, it blocks the effect of other opioids. So this is the flow chart of the induction phase. When a patient comes on day 1, we have to first see whether the patient is eligible for initiation on buprenorphine therapy or not. If yes, then is there a gap of more than 6 hours from the last opioid use, or the patient is experiencing any opioid withdrawals. If no, then we have to wait for the withdrawals to appear before the first dose of buprenorphine is to be given. And if there is more than 6 hours gap, or he is experiencing any withdrawal symptoms, we can initiate with 2 to 4 milligram of buprenorphine, and we have to observe for 2 hours. Then after that, if the patient experiences any opioid withdrawal or craving, then we have to administer more 2 to 4 milligram till a total of 8 milligram of buprenorphine is reached. And if the withdrawal symptoms are not experienced by the patient, then we can ask the patient to visit the center the next day. मैम ये NACP मैम नेशनल एड्स कंट्रोल प्रोग्राम की ओपियोइड सब्स्टिट्यूशन थेरेपी गाइडलाइंस 2004. Yes, ma'am. Then this is the flow chart. Yes. Yes. Then if 2 to 4 milligram of total, maximum you have to reach up to 8 milligram of buprenorphine. Then if the patient still experiences opioid withdrawal or craving, if he experiences, then we have to manage the withdrawal symptoms symptomatically and ask the patient to visit the OST center the next day. And if not, the patient can be sent to home and asked to come the next day. Now, if the patient returns to the OST center 24 hours after the last buprenorphine dose on day 2, then if the patient he experiences the withdrawal symptoms in the past 24 hours, or did the patient took any opioid in the past 24 hours? If no, then the daily dose that has been established, we have to continue with the previous day's dose. Then we can continue with the previous day dose which we have given him. And if he has experienced any withdrawal or consumed any opioid, we can increase the buprenorphine dose by 2 to 4 milligram, depending on the severity of the withdrawals or craving, and ask him to follow up the next day. Maximum dose of buprenorphine on day 2, it should not exceed 12 milligram per day. Like on the first day, it should not exceed more than 8 milligram per day. Then this was the scenario when the patient returned on the day 2 only. But if the patient didn't return on day 2 and return after 3 days or beyond it, then we have to ask the same question. If he has experienced any withdrawal or craving in the past 24 hours or has taken any opioid, if no, then the daily dose which was established, we have to continue with that. And if he has experienced any withdrawal, then we have to increase buprenorphine dose by 2 to 4 milligram every day, depending on the severity of the withdrawal. And maximum dose in this we can exceed up to, it should not exceed more than 20 to 24 milligram per day. If he has returned on day 2nd, then the maximum dose should not exceed 12 milligram per day. And if he has not returned on day 2, day 3 and beyond, then the maximum dose, it should not exceed 20 to 24 milligram per day. Then the maintenance phase. The goals of the maintenance phase are to maintain the patient on adequate doses of buprenorphine, to address other substance use by the patient, if any, to motivate and refer the patient for other services, including HIV diagnosis and treatment, to help the patient in regaining occupational, financial, and familial stability, to retain the patient in treatment, adhere to the treatment regime, and help prevent relapse to opioid use through injection or other routes, and to help the patient prevent shifting to other substance use. The clinician should continue the same dose of buprenorphine as used in the induction phase for stabilization. Any temptation to reduce the dose of buprenorphine must be avoided unless specifically warranted. Furthermore, the doctor must make inquiries on the following issues during every follow-up. Like, does the individual have withdrawals or craving despite his current buprenorphine dose? Has the individual used any other opioid or injections while on his current buprenorphine dose? And does the individual experience euphoria while using the opioids or injections? Then this is the graph which represents the pictorial representation of levels of opioid in the blood at different time point in a 24-hour cycle. We have to give buprenorphine in such a dose that it just reduces the opioid craving. We should not give the higher doses that it will lead to intoxication, nor we should reduce the dose so much so that it will lead to opioid withdrawal. We have to give buprenorphine in a maintained dose. While we can see the illicit opioid intake, when it is increased, it leads to opioid intoxication. Whenever the patient is whenever the individual is abstinent, it leads to withdrawal. The last one is the termination phase, and the goals are to taper and stop the buprenorphine medicine to ensure that clients have minimal discomfort during tapering of buprenorphine, to support the patient during tapering of buprenorphine and prevent relapse during the same, to help the patient in making decision regarding further treatment after stopping the opioid substitution therapy, and to motivate the patient for continued follow-up after he has been stopped from opioid substitution therapy. The termination phase begins with taking a decision to stop the buprenorphine, and it ends when the last dose of buprenorphine is administered to the client. Then decision to stop buprenorphine is taken when there is cessation of opioid and injecting use, cessation of illegal activities, improved relationships with the family, strong psychosocial support, well-maintained occupational functioning, and individuals' readiness to lead a medicine-free life. Then how do we taper the dose of buprenorphine? An outpatient, tapering can be done over 2 to 3 months of duration. In outpatient tapering, the tapering can be done in units of 2 milligram of buprenorphine every 4 to 7 days till the patient reaches a dose of 2 to 4 milligram of buprenorphine. Further tapering can be done in units of 0.4 to 0.8 milligram of buprenorphine every 4 to 7 days. While in inpatient, tapering can be faster than the outpatient and can be achieved in a 2 to 3 weeks of time. In inpatient setting, the daily dose of buprenorphine can be divided into 3 daily regime, and 0.4 to 0.8 milligram of buprenorphine can be reduced daily. Some of the patients, they experience greater discomfort as they reach the last few doses of buprenorphine. In such cases, the minimum dose can be continued for a longer period of time before we finally stop the buprenorphine. Then how to manage after termination of buprenorphine? Following termination, the patient must be educated on the importance of continued follow-up. The follow-up can be frequent initially, once in 2 weeks or so, and later at a frequency of once in 1 to 3 months. During such a follow-up, inquiry must be made regarding the patient's drug using status, occupational and familial functioning, as well as re-emergence of withdrawals and craving for opioid. Relapse prevention sessions must be continued during this phase. Then management of the common clinical situations, like sometimes while taking buprenorphine, the patient reports of vomiting. Then in this case, we can give them antiemetics. Constipation, it is a common side effect of buprenorphine. Then a sleep disturbance. Sleep disturbance is common among OST patients and include delayed initiation in sleep onset or frequent waking up in the night. Then in what we have to do when the patient has missed any dose. If the patient misses 1 day's dose of buprenorphine, it can be given on the same dose as before. If it misses 2 to 3 days dose of buprenorphine, then inquiry must be made by the doctor regarding whether the patient has consumed any opioid in the intervening period or whether is in withdrawal currently. And if the patient misses his dose of buprenorphine for more than 3 days, then he has to be restarted again from the first dose. Yeah, he should be treated as same as he was treated on the first day. This was according to the National AIDS Control Program guidelines. Now, according to the Indian Psychiatric Society guidelines of 2019, the Drug Controller General India, Government of India, has had earlier issued instructions in 2010 regarding fixed drug combination of buprenorphine plus naloxone, that the preparation shall be supplied to the designated de-addiction centers set up by the Government of India that were funded by Ministry of Health and Ministry of Social Justice and Empowerment, and hospitals with de-addiction facilities, and the list of these centers were to be made and periodically indicating how much quantity is supplied to these centers. But in 2019, the Drug Controller General India has issued new instructions regarding supply of buprenorphine 2 mg slash 0.4 milligram sublingual tablet, and fixed a combination of buprenorphine plus naloxone, buprenorphine 2 mg plus 0.4 milligram, and naloxone 0.4 mg plus 0.1 mg sublingual tablets. As per the new instructions, these can be supplied to psychiatric clinics, hospitals, nursing homes, de-addiction facilities, in addition to the de-addiction centers, which was previously the norm. And the take-home dose should be maximum for 7 to 14 days, and the number of tablets, they should not exceed more than 100. And for a maximum of 30 days, we can prescribe the medicine. But if it is, and we have to note it down in the OPD card or the file, whatever the patient has. And if it should never be prescribed for more than 30 days. According to the, these are my preferences. के बारे में डिस्कस किया मैम एनईसी मतलब जो नेशनल एड्स कंट्रोल प्रोग्राम है आईपीएस की गाइडलाइंस थी मैम मेनली में दोनों में मैम बुप्रेनॉर्फिन के बारे में मैम मैम मोस्टली बुप्रेनॉर्फिन यस मोस्टली वगैरह में तो हम लोगों ने बुप्रेनॉर्फिन पढ़ा था उसमें बुप्रेनॉर्फिन आ गया तो पढ़ लेना चाहिए था 2 साल बाद आ जाएगा बीच में बंद हो गया है अभी भी बंद हुआ है आई थिंक कितने साल आगे है कुछ तो कभी इसमें तो एक्चुअली मैं जब सूरत में से वहाँ पे भी खड़ी तो वो के कंट्रोल में था और जो डॉक्टर आए थे वो तो रिकॉर्ड में तो अंडर ऑब्जर्वेशन थे वो तो बोलते थे कि बुप्रेनॉर्फिन मतलब जो गाजियाबाद के सेंटर में भी वो 15 दिन 20 दिन से दे देते हैं पेशेंट बोलते हैं हम जॉब करेंगे या एक साल मैम इसमें जो 2014 में थी उसमें मैम मोस्टली डायरेक्टली ऑब्जर्व ट्रीटमेंट वाला ही होता है yes 3 days eat फिर 7 to 14 take away ना तो हम लोग बोल देते हैं और कम सिर्फ कॉल सिम्टम्स वो करने फिर ये भी लाइक इट कैन ऑलवेज स्टॉप अप वो जिधर बुप्रेनॉर्फिन के ऊपर भी पेशेंट ने अब्यूज कर दिया अगर 8 मिलीग्राम के ऊपर 24 मिलीग्राम होते तो अब्यूज करेगा भी तो इट विल नॉट गिव हिम अ किक जस्ट लाइक मैनर्स one of the reasons is cost like buprenorphine is less costlier than the real cost of buprenorphine का 400 रुपये का पड़ेगा तो 500 रुपये का ले लेगा ये 2020 टीम्स वालों ने बताया था पंजाब गवर्नमेंट for that was for specifically for opioid substitution उसमें जो गाइडलाइंस है उसमें 3 days का उसमें ये भी है कि जो आपका सेंटर है it has to be open 365 and always and also on holidays it has to be sorry 2 hours because your patients you are dispensing them for 3 days so patient will be coming any day a patient can come so minimum of 2 hours you have to open that is the and you should not dispense 3 days of फिर ये tablets वाला भी है yes initial NDPS है also it was given in IPS guidelines also Indian Psychiatric Society in 2019 given that 100 tablets जो dose है ना I think which somebody can carry NDPS उससे tablets around this up 2 मिलीग्राम वाली ऐसा ऐसा है 200 mg कितना mg आपके पास तो ये you can't carry it across state boundaries कायदे से हम लोग अगर कोई इग्नोर से आ रहा है उसको नहीं दे सकते that is smuggling because it can't cross state boundaries कई बार अगर हरियाणा से आ गए गोवा से आ गए MP, Bihar,
like you shouldn't write in your prescription. Like one of the doctors who was arrested was because of that. Like he was like practicing in Dehradun, he goes to उडुपी से वो आगे चला गया मुजफ्फरनगर बाउंड्री क्रॉस कर लिया तो वो वहां पे जाके क्लिनिक लगा कि बेसिकली विद अ ह्यूज अमाउंट ऑफ क्रॉस द स्टेट कांट क्रॉस फिर वो भी एक प्रॉब्लम है उसके बाद तो एस्टैब्लिशमेंट है तो आप उसके बाद 200 mg है हाँ मतलब आई एम नॉट श्योर 100
एक्चुअली वो उसमें ना जो क्वांटिटी है ना कि आप पर्सनल यूज से कितना ले सकते हो कितने से ज्यादा ले रहे हो उससे बंकिंग करके मतलब तो उसमें उसमें यही है मतलब वो अभी एक प्रेजेंटेशन किसी का था तब हमने वो कैलकुलेट करके 100
मिलीग्राम का हम लोग कैसे कर सकते जैसे अगर 14 लाइक वे आई हैव 14 डेज का अगर आप देते हो यू कैन गिव 8 मिलीग्राम पर डे तो दे सकते हो तो अगर आप 8 मिलीग्राम पर डे के हिसाब से भी आप किसी को अगर 10 डेज का दे रहे हो तो 80 टैबलेट से बन जाएगा 14 डेज में उतना ही बन जाएगा तो लाइक लीगली यू कैन प्रिस्क्राइब लाइक 20 grams 20 grams 20 to 100 to 30
small quantity of commercial quantity यहाँ पे एक between small and commercial quantity तो है हाँ तो small quantity 2 ग्राम है ना ठीक है ना 2 ग्राम मतलब 100 टैबलेट तो है एक का 2 मिलीग्राम हुआ 1000 मिलीग्राम 2 ग्राम small quantity में एक साल small quantity एक साल जो 10 ग्राम commercial में 10 का
small quantity is like if a person is using small quantity and he has to be an addict. That is he should diagnose or he should that is why it is taking the patient. यहाँ पे कई लोग जो आते हैं वो कहीं कहीं अपना एडिक्ट है इसका प्रिस्क्रिप्शन आ गया तो you can carry any cancer that I am addict. उसमें फिर ये if he is willing for counseling and treatment then he can escape. फिर वो है ना then he can escape but somebody who is not an addict you can't even have minimum. You can't possess even minimum. It is not like somebody who is possessing minimum amount or say less than commercial amount per person, then he has to be an addict. So somebody who is not an addict cannot possess even that. So that means you are selling. If you are not consuming, that means you are selling, distributing or whatever.
That's why all the I am coming personally. Why do they say that? Because that way you can escape.
वही तो शाहरुख खान का बेटा काउंसलिंग इतनी करा रहा था उसके बाद में ultimately he was acquitted but they were trying to say that he was involved in trafficking smuggling so somebody buys in large quantity okay had he called number of people together for a party and he provides them that also is like it is not कि आप जो है पैसा ले रहे हो नहीं ले रहे हो वो तो कौन प्रूव कर पाएगा okay coming back to this, what do? You do opioid substitution therapy look at that technically we are not doing opioid substitution like this is लोग जो करते हैं कि symptomatic treatment tramadol देते हैं they just symptomatically treating and then the goal is always to gradually taper down or in our case in our scenario all of us we are treating our goal is always get 2 milligram per stable हो गया अब उसको और कितना कम कर सकते हैं कितना कम कर सकते हैं it is not like कि हम लोग एक पे सेट होकर के जैसे वो 4 मिलीग्राम मतलब 2 मिलीग्राम पर डे तो हम लोग देते ही, मतलब जो एक कांस्टेंट हुआ 2 मिलीग्राम पर डे, 8 मिलीग्राम से रेयरली प्रिस्क्राइब होता है। 8 मिलीग्राम से अगर कोई ले रहा है तो फिर वो अब्यूज ही नहीं कर पाएगा। यहाँ पर इसीलिए प्रॉब्लम है कि 2 मिलीग्राम देता है उसको विड्रॉल होता है, तो वो यूज कर लेता है। तो गोल इज टू सिम्टोमेटिकली विड्रॉ, जैसे जिन लोग हॉस्पिटलाइज भी करते हैं, यहाँ पर ट्रामाडोल की जगह को आप यूज कर सकते हैं। डे 1 पे आप 4 mg दे दो, उसको 8 mg दे दो, उसका विड्रॉल कम हो जाएगा। फिर जैसे आता है आप उसको मिल जैसे थेरेपी करते हो, वहाँ पर जैसे लेवल होती है मिलीग्राम वजह से, वहाँ पर तो हम लोग यही करते थे। वहाँ पे 0.2 से 0.4 मिलीग्राम के भी थे टैबलेट्स अवेलेबल। तो वो टेपरिंग में बहुत ईजी है। 0.2 कि आप उसको 2 mg पे ले आए, फिर 2 mg के बाद में फिर उसको टेपर करना मुश्किल हो जाता है। 0.4 TDS के लिए आप यूज करो। If it draws, out the smack कर तो क्या है कि it is like the end of the day receptors are limited, no? तो चाहे जितना भी वो एक मिथ है हमारा, अगर वो ज्यादा क्वांटिटी है तो उसको ज्यादा सीवियर एडिक्ट है। ठीक, पर यहाँ पर जो हम लोग देखते हैं दे आर माइल्ड टू मॉडरेट अब्यूज। यहाँ पे लोग सचमुच में नहीं करते। जैसे some patients I have seen from like, how many patients have you seen rhinorrhea? जो withdrawal symptoms होता है rhinorrhea, lacrimation, वो हमने देखते नहीं यहाँ पे। like you see patients from Punjab, if you will truly see patients who are using 1-2 milligrams every day, then they are almost rhinorrhea, lacrimation तो बहुत छोटा होता है, and vomiting, and they are just like pain, very severe pain. It is deciding, you decide what you want to do. Opioid substitution में तो higher dose दे, OST में higher dose दे, because your aim is that he does not use the other. Okay, so you give enough legal opioid to the patient so that he does not abuse smack. While he's taking buprenorphine, he should not be able to abuse smack that much more, because it is partial agonist. He should not be able to abuse. Even if he abuses, he will not get a kick. He will not get a high. Okay. क्या कहते हैं वो हाई डोज में पता चला। हम लोग तो सिर्फ एक सिम्पटैटिक उसके लिए दे रहे हैं ट्रीटमेंट के लिए। दैट इज बेसिकली अब्यूज।
पैराडॉक्सिकली पेशेंट इज वेरी गुड की गोली खाएगा, हमने गोली बंद करवा
हाँ, वो भी है। और आप वो बोल भी सकते हैं कि सर ये आते हैं अचानक से, स्टेबल चल रहा है पेशेंट, 2 मिलीग्राम पे सब काम कर रहा है, कुछ कर रहा है, अचानक से आएगा कोई रिलेटिव, सर ये दवाई क्या है, ये नशे की दवाई है तो ये आप ये मना थोड़ी कर सकते हैं कि क्या है। सब्स्टिट्यूशन में क्या है तो उसको ओपिएट कैटेगरी की है।
can't decide a dose what we have to give on the first day to the patient.
No. See, the problem is not about the medical necessity, how much you can take. The problem is the situation. Okay, there are two kinds of, in some countries, opioid substitution is not at all given. Okay, so in there the treatment is abstinence. कोल्ड करके आप जाओगे आपको वो भर्ती कर देंगे बाहर, ठीक है। So countries like Singapore, Dubai, like UAE, so there your treatment is abstinence. Okay, then there are countries where the treatment is substitution. They don't go for the treatment of abstinence is not there. Like the goal of abstinence is not there. Like in US, there they go for methadone, OST. So it is really available, and they will think, हाँ आप opioid ही लो, ले लो। कि वो abstinence के लिए फिर बाद में जब पेशेंट खुद से बोलता है कि मैं करता हूँ, तो फिर वो मंथ्स लेकर के कर सकते। but there the treatment is OST, and there is a group like in which you see somebody from Japan कि नहीं वो पढ़ा देते पेशेंट कि आपको ये तो चाहिए, आपको ये खाना है. Okay, so we are in the middle, India. Neither are we truly on abstinence or substitution. Both the things are available. At one time, buprenorphine was very easily available, just like tramadol. All people were dispensing. I think 2010-12 में यहाँ पे everybody was dispensing. Like dispensing क्या easily मिल रही थी. सन की आती थी, क्यूटिक, ये वो बुप्रेनॉर्फिन बहुत इजीली मिल जाती. तो उसमें वो भी यूज करते थे लोग. अब फिर उसके बाद में ये हुआ कि उस पर ही लोग जो है क्लिनिक ऐसी होगी कि 100-200 पेशेंट रोज के आ रहे हैं सिर्फ बुप्रेनॉर्फिन लेने के लिए. तो फिर सस्ती भी कुछ ना. इट इज वेरी डिफिकल्ट. आपका मासेस को बताना पड़ेगा कि आप सब्स्टिट्यूशन करो तो पता है कि आपको नशा ही दे रहे हो. फिर जो है हम लोग बीच में कायदे से तो 8 मिलीग्राम 12 मिलीग्राम कितना देना चाहिए. पेशेंट खाता रहेगा उसको टॉलरेंस हो जाएगी, उसको हाई नहीं होगा, काम अपना करेगा. जब बिल्कुल स्टेबल हो जाएगा यू नो. फिर मिथ ये है कि हम लोग जो कहते हैं कि लाइक सब्सटेंस अब्यूज इज जस्ट लाइक सब्सटेंस. इट इज नॉट पैराफिनेलिया पूरा. आपका कंपनी है, आपका वो मेथड है. आदमी जब उससे निकलेगा तो कुछ काम ढंग का करेगा ना, वरना तो ऐसे लोगों के साथ में रहेगा वो. फिर तो यूज करते हैं. हाँ, हार्म रिडक्शन इज द गोल. कि आईवी नहीं यूज करो. जो पहले आपने दिखाया था कि उसमें ये था कि आप उसी को बुप्रेनॉर्फिन दोगे जो आईवी ड्रग यूज करता है. स्मैक करता है, वो चेज करता है, उसको तो देना ही नहीं है वैसे. तो इट इज जस्ट फॉर हार्म रिडक्शन. चलो ठीक है, वो आईवी कर रहा है, उसको एचआईवी हो सकता है, तो इसलिए आप उसको ओरल हम लोग इधर गिल्टी कॉन्शियस हम दे दे रहे हैं उसको. चलो तेरे को पता एचआईवी से बचा लिया. अब वो कह रहे, दूसरा वो कह रहे कि नहीं, इट्स अ ट्रीटमेंट. गिव एंड दैट टू इन वेरी हाई. 8 मिलीग्राम से देना ही है. व्हाट्स भी है 8, 16, 24 जो तुम बता रहे हो ना कि मैं borrowed from some article and what's the में भी ये 8 to 24 मिलीग्राम ओएसटी का डोज. और तो जो है हम वो देते हैं. दूसरा जो तरीका है जैसे कि आप विड्रॉल में यूज करते हो, तो हम लोग तो जो स्ट्रेटेजी वो करते हैं जब आपका एक पेशेंट 8 मिलीग्राम पे स्टेबल चलता है, उसके बाद वो कहते हैं कि आई वांट टू बिकम एब्सोल्यूट. वो स्टेप करते हैं हम तो हमेशा वही करते हैं. कि वो फिर कहते हैं कि चलो ठीक है, 2 मिलीग्राम कर दिए 1 महीने के लिए, तो हम लोग नहीं करते हैं कि 6 मिलीग्राम पे स्टेबल है तो 2-3 महीना स्टेबल रहा कर देते हैं, 4 मिलीग्राम कर देते हैं. फिर उसको फिर 2 मिलीग्राम कर देते हैं. तो ये है, वी आर ऑलवेज ट्राइंग फॉर एब्सोल्यूट. आवर ट्रीटमेंट गोल इज ऑलवेज एब्सोल्यूट. और यहाँ पे इंडिया में ट्रीटमेंट गोल एब्सोल्यूट ही रहता है हमेशा. तो हम 2 मिलीग्राम भी देते तो वही सोचते रहते कि मतलब इसके बिना नहीं रह पाएगा, तो खाता रहे, उसका बंद तो करनी है ये.
Although the 7 days without opening with the naloxone, and there should be the 7 days she had to survive, and eventually naloxone should be cured as well. For the 7 days, the show her the opening that she's supposed to leave the naloxone, and if she gets the naloxone, then she'll be okay for me. No one puts around that. In the end, she has to put it, and then she takes naloxone, she's going to get good on this, but naloxone is important. In India, there is a lot of there's medical medicine, but here I think कि नशा कर रहे हैं. Treatment is also seen as नशा कर रहे हैं. Why financial?
इसमें जो substance abuse का है, like thing is like there is a baseline. Somebody emotional, this is baseline. Okay, so he gets a high, and if he doesn't use, he comes to the baseline. That is the hypothesis. It does not happen in reality. What happens is that if he is chronically using, then if he stops, then he does not come naturally on the baseline, he goes below the baseline. So there is inherent dysphoria, boredom continuing in the person. Okay, so this is proof that like so like if somebody is used for 1 year and then you stop the opioid, within 2-3 weeks he will come back to zero baseline. It does not happen. he goes below the baseline. वो जरूरी है. He'll be in dysphoria for months. Physical symptoms चले आएंगे, but that is why OST, like OST is like he continues taking any. जो इसमें आपने यूज किया ना OST में क्रोनिक यूजर लॉन्ग टर्म, वो अगर कोई 3-4 मंथ यूज कर रहा है, लेस देन 6 मंथ से, तो काफी OST ओवर एब्सटेंस यूज आता है. यहाँ पे लोग होते हैं 500 रुपए की पी रहे हैं, नहीं मिलर नहीं किया. यहाँ पे हमारे 90% ऑफ पेशेंट्स आर लाइक दैट. 500 मिली, 500 रुपीज टू 1000 रुपीज का यूज कर रहे हैं और नहीं मिला तो नहीं कर रहा है. काफी कम लोग हैं जो कि एक्चुअली डिपेंडेंट है कि लाइक अगर सुबह में नहीं है तो दोपहर तक withdrawal state बहुत जो है. if you will see such patients, like then you'll know. तो ये I was surprised कि आप इसे $0 ये सब से तो ऐसा नहीं होता आपको. तो जो
लोग क्वालिटी
हाँ ये बात भी है. पेशेंट्स हाँ नहीं, और साथ में पता नहीं क्या क्या मिला के दे, वो डिलीरियम में चले जा रहे हैं कभी. हाँ ब्रेडिकार्डिया हो रहा है, डिलीरियम हो रहा है, और जो है विटामिन ये भी है. Even in Lucknow, when we saw patients, they were like, once a patient, like, their withdrawal symptoms are known. Withdrawal में death तक होती है, mortality तक है ना. pulmonary edema हो जाता है, coughing इतनी भयंकर होती है, coughing और क्या कहते हैं breathlessness. तो भाई पर क्या कहते हैं हम लोग एक मूवी पे डॉक्यूमेंट्री वो ऑक्सीटोसिन
पेन किलर
तो देख के मैं
सीरीज में डॉक्यूमेंट
काफी
सीरीज अच्छी है सर, बहुत अच्छी.
तो मैं ये बोल रहा था कि we will be in a flux for a period of time because either 3 to 4 or 8 to 9. Please follow through, be a little proactive so that our sessions continue. Otherwise, we have to start from 8 to 9. Okay. So एक दिन पहले से डिसाइड करके and start from 1:30 to 1:45 so that we finishing time. So we continue with this. So you should finish off all your work, written documentation work by 1:30. जो on call है वो रहेगा on call. Okay. And if required, तो वैसे काम हो जाएगा. फिर बाद में तुम लोग जो है दीवानी और मंदिर के साथ प्रैक्टिस भी करते हो. आप ऊपर जो है वैसे ब्लैक बोर्ड है वो हटवाना है, प्रोजेक्टर लगा हुआ है, प्रोजेक्टर लगा हुआ है वहां पर लोग करते करना. वहां पर ये रहेगा कि बिकॉज ओपीडी से आ जाएंगे फटाफट से असेंबल जल्दी हो जाएंगे. द टाइम इट टेक्स अस टू असेंबल लाइक एवरीबॉडी इज टू कम वार्ड से फिर कॉल्स नहीं आता है तो इसको जा रहा है पेशेंट देखता है. We will make that upstairs functional. Put a demand for some wheelchairs there. Okay. So the target is that all your discharges are in total. Like you should give by 12 so that they are out of the ward. पहले से proactively देखो किसको डिस्चार्ज करना पहले से आलो गवर्नमेंट इंटर्न से फॉर्मेट से तो भाई बस पहले प्रिंट निकाल कर रखो एडवाइस और डिस्चार्ज बाद से later position because if it does not work then you have to implement or it's the 3 से 4 they will